Hello everyone. The purpose of this lecture is to provide a review of key concepts in the biology and clinical aspects of medulloblastoma in children as an adjunct to the chapter in the 8th edition of Humans and Women Neurological Surgery. My name is Kali Areshka and I am a neurosurgery resident at the University of Toronto, and I will be narrating this lecture for this chapter on behalf of my co-authors Dr. Fujita and Dr. Rutka. In this lecture, we will begin with a historical overview before discussing the epidemiology, pathology, molecular subgroups, clinical presentation, diagnostic imaging and workup, staging and prognostic factors, treatment, follow-up, quality of life in survivors, and finally discuss expected future developments in the science and clinical care of children with medulloblastoma. Medulloblastoma was initially described in the 1920s by Dr. Harvey Cushing and Dr. Percival Bailey. They referred to this tumor as Medulloblastoma cerebelli and described many classic features of this tumor, including the tendency to arise from the cerebellar vermis and propensity to exhibit leptomeningeal metastasis. They recognized key pathological features such as cells with small round nuclei with minimal cytoplasm and a high mitotic index. They proposed that these tumors arose from an embryonal progenitor cell called a medulloblast. Finally, they recognized that these patients had very poor outcomes with surgery alone, but did have a single long-term survivor in a series of 61 patients who underwent focal radiotherapy. Radiotherapy delivered to the entire craniospinal axis developed as an essential adjunctive therapy over the following decades, leading to Patterson and Farr's landmark series describing the use of craniospinal radiation, leading to a 60% 3-year survival rate in 27 patients. Over time, clinical factors that predict prognosis have been proposed, and the metastatic stage system proposed by Chang in 1969 continues to hold prognostic value and is used in clinical care and will be described in greater detail later in this lecture. Starting in the 1970s, trials began incorporating chemotherapy into treatment regimens for medulloblastoma, both in an attempt to improve survival and reduce the dose of craniospinal radiation. These trials have resulted in a reduced dose of craniospinal radiation for many patients and a gradual improvement in overall survival over the decades. Finally, advancements in the understanding of the molecular underpinnings of medulloblastoma, initially through the recognition of recurrent mutations in the sonic hedgehog and Wnt signaling pathway genes, has led to the identification of 4 molecular subgroups of medulloblastoma, which is paving the way towards refined treatment protocols and targeted therapies. Medulloblastoma is the most common malignant pediatric brain tumor and a leading cause of cancer-related death in children. These tumors account for up to 10% of brain tumor diagnoses in children, with an estimated incidence of 2 to 7 cases per million children per year. There is a male predominance with an estimated ratio of 1.5 to 1. These tumors can occur from infancy through adulthood, but it becomes very rare after the 4th decade of life. There are peak incidences in the age ranges between 1 and 4 and 5 and 9. There are some studies that have suggested trends of increased incidence of medulloblastoma among certain ethnicities. Finally, a significant number of cases are associated with genetic predisposition syndromes, and we'll discuss these in greater detail later. There are currently 4 widely recognized histological subtypes. The appearance of classic medulloblastoma, touched on in the last slide, is that of a dense sheet of small basophilic cells with little cytoplasm and round to oval hyperchromatic nuclei. A high mitotic index is common. Neuronal or glial differentiation are seen in up to half of cases. The desmoplastic nodular and MBEN variants are two additional subtypes with many similarities. The desmoplastic nodular variant is characterized by pale, reticulin-free nodules surrounded by reticulin-positive collagen fibers and represents area of more advanced neuronal differentiation. Medulloblastoma with extensive nodularity, or MBEN, differs in that the reticulin-free zones become large and enriched with a neuropil-like tissue, which resembles the streaming pattern of central neurocytoma. The reticulin-rich internodular areas are significantly decreased. Finally, the large cell anaplastic medulloblastoma subtype is characterized by both anaplastic features, such as nuclear pleomorphism, nuclear molding, cell-cell wrapping, and a high mitotic index, and large cell components containing spherical cells with round nuclei, open chromatin, and prominent central nucleoli. Research in the early 2000s began to recognize a subset of medulloblastomas that featured upregulation of the Wnt and sonic hedgehog signaling pathways. Later, primarily through transcriptional microarray studies, research groups began to propose molecular subgroups of medulloblastoma based on similarities of transcriptional profiles. Wnt and sonic hedgehog subgroups were routinely recognized, with some variation in the proposed non-Wnt and non-sonic hedgehog subgroups. Ultimately, an international consensus of 4 molecular subgroups was reached: Wnt, sonic hedgehog, group 3, and group 4. Of note, a subset of up to 10% of non-Wnt and non-sonic hedgehog tumors failed to be assigned to a particular subgroup because of some biological overlap between group 3 and group 4 tumors. Since this initial subgroup definition, some groups have proposed molecular subtypes of medulloblastoma, which will also be touched upon briefly in this section. However, it is important to realize that this is an evolving area of research. An overview of the subgroups is provided here, and we'll discuss each subgroup in subsequent slides. The Wnt subgroup is the rarest subgroup, accounting for only 10% of cases. It is absent in infants but occurs in all other age groups. It is associated with excellent prognosis, with overall survival exceeding 95%. Progenitor cells in the lower rhombic lip are the suspected cell of origin in this subgroup, which may explain why this subgroup often exhibits involvement with the cerebellar peduncles and brainstem. Another clinical feature of these tumors is that they have a leaky blood-brain barrier, which has been proposed as a reason why these tumors are more sensitive to treatment and why they often have a hemorrhagic component. Molecularly, these tumors are driven by aberrant activation of the canonical Wnt signaling pathway, which is pictured on the bottom right. Normally, this pathway is activated by a Wnt protein that binds to frizzled. Frizzled then sends a signal to disheveled, which deactivates a destruction complex that normally targets beta-catenin for degradation. When Wnt signaling is activated, beta-catenin accumulates in the cytoplasm and translocates to the nucleus and activates transcription of target genes that cause cell proliferation and migration. Common alterations in this subgroup include activating mutations in CTNNB1 in the third exon. This gene encodes beta-catenin and results in activation of this pathway in the absence of Wnt proteins. This mutation frequently co-occurs with monosomy 6, which is the only recurrent cytogenetic change seen in this subgroup. The next most common Wnt pathway alteration is APC mutation, which can occur as both a germline mutation or sporadically. Finally, this subgroup has the second highest overall mutational burden, and commonly altered genes are listed in the figure on the right. 2 subtypes of Wnt medulloblastoma have been proposed, alpha and beta. The alpha subtype was somewhat younger, and all patients had monosomy 6. In comparison, the beta subtype was slightly older, and less than 50% of cases had monosomy 6. The sonic hedgehog subgroup is the second most common subgroup. It is quite heterogeneous clinically and in some respects molecularly as well. It occurs across all age groups but is the most common in infants and adults. There is a balanced gender ratio. All histological subtypes are represented, but the desmoplastic and MBEN variants are most frequently observed in sonic hedgehog tumors compared to the other subgroups. Recurrences typically occur locally rather than metastatically. This tumor is driven by sonic hedgehog pathway activation. Normally, the sonic hedgehog pathway inactivates patch 1, resulting in loss of inhibition of SMO, leading to signaling cascades through SUFU or MIC-N, resulting in downstream expression of target genes, as pictured in the figure on the bottom of this slide. Multiple sonic hedgehog pathway genes are altered in sonic hedgehog medulloblastoma cases, including loss of function mutations or deletions in patch 1 and SUFU, activating mutations in SMO, and amplifications of MIC-N and GLI1 or GLI2. MIC-N amplification has been associated with poor prognosis, along with mutations in TP53, which result in genomic instability. TERT promoter mutations are also frequent, especially in adult cases. Cytogenetic events, such as loss of 9q, which contains the genes encoding patch 1 and ELP1, and 10q, which contains SUFU, or 17p, containing TP53, are common cytogenetic events that often cause loss of heterozygosity of the aforementioned genes. Subtypes of medulloblastoma have been proposed to help better understand the clinical and molecular heterogeneity within medulloblastoma subgroups. The goal of these further refined subtypes is to provide tools to improve prognostication and therefore affect treatment decisions for clinicians, and to provide researchers with the ability to identify targeted treatments that might be effective within certain subtypes. The proposed subtypes of sonic hedgehog medulloblastoma arguably have the most intuitive clinical relevance, and there is quite strong overlap between the subtypes proposed by Cavalli, Kuhl, Schwalb, and Robinson. The subtypes proposed by Cavalli, namely alpha, beta, gamma, and delta, arguably most holistically capture the entities proposed by the other groups, and I will discuss that system further here. Sonic hedgehog alpha occurs in children and teenagers. This is a higher risk group within the sonic hedgehog subtypes with 5-year survival of 70%. LCA histology occurs in almost 25% of cases, while this is rare in other subtypes. Among the molecular changes outlined in the table on the left, TP53 mutations, which occur in approximately 1/3 of tumors in this subtype, are of particular clinical relevance, since they are associated with survival rates of just over 25%, as you can see in the survival curve on the bottom. Recently, ELP1 germline mutations in sonic hedgehog medulloblastoma were described, and these almost exclusively occur in sonic hedgehog alpha tumors. These mutations are mutually exclusive with TP53 mutations and are associated with over 90% 5-year overall survival, suggesting that there may be additional useful stratification within sonic hedgehog alpha tumors. The beta and gamma subtypes together account for the majority of cases in infants and young children. Clinically, sonic hedgehog beta has poor prognosis and the highest rate of metastasis. Broad chromosomal gains are common, and P10 loss resulting in PI3K pathway activation is enriched in this subtype. Sonic hedgehog gamma is associated with excellent clinical outcomes and contains most of the MBEN histology tumors, which are also associated with good outcomes. Of note, survival in this group is good regardless of MBEN subtype, suggesting that this subtype system may provide a better way of identifying young sonic hedgehog patients with good prognosis compared to histology alone. Cytogenetic changes are rare in the sonic hedgehog gamma subtype. Finally, the delta subtype is essentially an adult disease and survival is excellent. Molecular features include TERT promoter mutations in over 90% of cases and a high overall mutational burden. Recently, mutations in the non-protein coding U1 spliceosomal RNA family were identified in 97% of sonic hedgehog delta cases. These RNAs are responsible for the recognition of splicing sites in pre-messenger RNA, and the mutation results in alternative splicing of multiple genes, including sonic hedgehog pathway genes. These alternatively spliced mRNAs result in protein variants that may make these tumors particularly susceptible to immunotherapy. Group 3 medulloblastoma occurs primarily in infants and young children and becomes rare among adolescent patients. It is twice as common in males, and LCA histology occurs most frequently in this subgroup compared to the other subgroups, as depicted by the bar chart on the right, where the orange bar represents proportions of LCA histology in the various subgroups. This group has high rates of metastasis and the worst survival of all subgroups. The most common recurrent events in this subgroup are MYC amplification, which is associated with a very poor prognosis, and GFI1 or GFI1B overexpression via an enhancer hijacking event. Recurrent mutations are rare. Instead, epigenetic mechanisms may be key in group 3 tumorigenesis. Less consensus exists in group 3 and group 4 subtype definitions. In fact, one proposed group 3 and 4 methylation subtype system contains subtypes that overlap between these two subgroups. Cavalli et al. Proposed 3 subtypes of group 3 medulloblastoma, namely alpha, beta, and gamma. Group 3 alpha contains 60% of group 3 infants and has a high rate of metastasis, but is associated with the best prognosis. Group 3 beta has the oldest median age, 7.5 years, and enrichment of GFI1 or GFI1B overexpression. Group 3 gamma is defined by enrichment for MYC gainer amplification and is associated with the worst prognosis, with 5-year overall survival of approximately 41.9%, even when controlling for MYC amplification status. Group 4 medulloblastoma is the most common subgroup and is 3 times more common in males. It is generally a tumor of childhood and adolescence and carries an intermediate prognosis. The most highly recurrent genetic event is a tandem duplication of SYNCAP, resulting in upregulation of PRDM6 via enhancer hijacking. A number of different genes involved in histone modifications are currently mutated, suggesting epigenetic dysregulation is central in group 4 biology. Cytogenetic changes are common, and isochromosome 17 is present in 80% of cases. Cavalli et al. Proposed 3 subtypes of group 4 tumors. These subtypes don't result in very obvious clinical phenotypes. There may be a trend towards survival difference between these subtypes, but it is not statistically significant. The distinguishing molecular features are MYC-N amplification for the alpha subtype, SYNCAP duplication and PRDM6 upregulation for the beta subtype, and enrichment of CDK6 amplification in the gamma subtype. When the initial subgroups were proposed, some degree of overlap existed in the molecular signatures of group 3 and group 4 tumors. A proposed methylation-based subtype classifier attempts to account for this overlap in the 8 subtypes proposed in this slide. While a complete review of this classification is beyond the scope of this presentation, I'll touch on a few key points. Subtypes 2, 3, and 4 are group 3 subtypes. Of note, subtype 4 is associated with better outcomes, especially in children over the age of 3 who receive radiotherapy, suggesting that this subtype may be more radiosensitive. Subtypes 1, 5, and 7 contain both group 3 and 4 tumors, and subtype 5 appears to be associated with poor outcomes. Subtypes 6 and 8 contain only group 4 tumors. Given their embryonal origins, a lot of researchers have attempted to identify the cell of origin for medulloblastoma. Clinically, this likely impacts the difference in anatomical location of the various subgroups, which will be discussed further later. Additionally, it suggests that these cells may undergo transformation events early in embryogenesis. Wnt medulloblastoma likely arises from lower rhombic lip progenitors in the developing brainstem. Sonic hedgehog medulloblastoma arises from granular cell precursors. Group 3 medulloblastoma arises from early progenitor nestin-positive stem cells. And Group 4 medulloblastoma likely arises from unipolar brush cells or glutamatergic cerebellar nuclei, or both. Accurate ascertainment of medulloblastoma subgroup has become an essential part of the diagnostic workup. DNA methylation profiling is the gold standard technique for subgroup classification, as it provides superior accuracy for subgroup diagnosis and allows for diagnosis of proposed molecular subtypes. Cost will vary by center, but is currently approximately $550 in Toronto. Other techniques include array-based RNA expression analysis, nanostring, and minimal methylation classifier assays. Immunohistochemistry can diagnose Wnt and sonic hedgehog tumors and differentiate them from non-Wnt non-sonic hedgehog tumors, but it cannot reliably diagnose group 3 or group 4 tumors. Fluorescent hybridization in situ can be used to identify chromosomal changes, rearrangements, and focal amplifications. Testing for secondary molecular characteristics, such as CTNNB1 exon 3 mutation status in Wnt tumors, and prognostic features such as TP53 mutations in sonic hedgehog tumors and MIC amplification in group 3 tumors, and is an important adjunct to subgroup classification. Numerous genetic predisposition syndromes causing medulloblastoma have been reported with varying penetrance, and many of them are listed in the figure in the top right. These vary in frequency between subgroups, with up to 20% of sonic hedgehog tumors being caused by genetic predisposition syndrome in a study of 1,000 patients. With the recent report of ELP1 mutations causing up to 14% of sonic hedgehog medulloblastoma, this estimate may be as high as 40%. Approximately 6% of Wnt tumors occur in patients with familial adenomatous polyposis syndrome, while germline mutations are rare in group 3 and group 4 patients. The most common syndromes and mutations that cause the highest proportion of cases are ELP1 mutations resulting in sonic hedgehog medulloblastoma, Gorlin syndrome, which is caused by patched1 and SUFU mutations and results in sonic hedgehog tumors, Li-Fraumeni syndrome, which is caused by TP53 mutations and results in sonic hedgehog tumors, and mutations in the APC gene, resulting in Wnt medulloblastoma. Based on the associations with subgroup outlined in the previous slide, Waszak and colleagues proposed the following testing protocol. Wnt tumors should have testing for APC germline mutations when there is an absence of CTNNB1 mutation. Children with sonic hedgehog tumors have high incidence of germline TP53 mutations. In addition, the recently described ELP1 germline mutation should be assessed in this age group. Infants with sonic hedgehog tumors more commonly have patch1 or SUFU mutations, as seen in Gorlin syndrome. Germline mutations in group 3 and group 4 tumors are rare, and testing should be directed towards patients with a family history of BRCA-associated cancer or homologous recombination repair deficiency. Medulloblastoma usually presents subacutely with a median duration of symptoms of 4 weeks, and 3/4 of patients present in less than 12 weeks from symptom onset. The most common presentation is that of increased intracranial pressure with headache, vomiting, and lethargy. Papilledema is the most common sign. A notable minority of patients can present in extremis. Common symptoms in older children include headache, nausea, clumsiness, fatigue, poor school performance, or diplopia, while younger children often present with irritability, weight loss, failure to thrive, and may be worked up for gastrointestinal symptoms. Common signs include truncal ataxia, nystagmus, and limb ataxia. Spinal metastasis can cause back pain, gait difficulty, and bowel or bladder dysfunction. The pre-diagnostic interval appears to vary by subgroup, with a median of 8 weeks to presentation for Wnt and group 4 patients, while median time to presentation for sonic hedgehog and group 3 patients is 2 and 4 weeks, respectively. MRI is the standard of care diagnostic imaging modality for medulloblastoma. CT scan should be reserved for patients presenting in extremis where patient safety precludes MRI. If possible, MRI of the craniospinal axis should be performed preoperatively because postoperative artifact can obscure the detection of leptomeningeal metastasis. A midline tumor location associated with the cerebellar vermis and fourth ventricle is the most common anatomical pattern and is displayed in the images shown. More rarely, medulloblastoma can arise in the cerebellar hemisphere or cerebellopontine angle. They are most often between 3 and 6 centimeters in size. They have a characteristic hypointense T1 appearance and hyperintense T2 weighted imaging appearance. However, the T2 signal tends to be more heterogeneous. Diffusion restriction is present throughout, with a high signal on diffusion weighting imaging and low signal on apparent diffusion coefficient, which is shown in panel B of the lower row of figures. Contrast enhancement is present in nearly all cases, but varies from intense and homogeneous to subtle and heterogeneous. Other common features are peritumoral edema, which typically only extends about 1 centimeter from the tumor margins, intratumoral cysts, as pictured in the bottom row of images, necrosis, calcifications, and intratumoral hemorrhage. 3/4 of children have evidence of hydrocephalus on initial imaging. As mentioned, complete imaging of the craniospinal axis is essential in the work of a medulloblastoma. The reason for this is that medulloblastoma has a propensity to metastasize to the leptomeninges and the ependyma. Metastases typically demonstrate contrast enhancement, although, like the primary tumor, this can be variable. Diffusion restriction is present in most metastatic deposits. Metastasis can demonstrate a laminar morphology, often referred to as sugar coating. Figures A to D show diffuse contrast-enhancing laminar leptomeningeal metastasis intracranially and along the spinal cord. Figure E shows an example of a case with a primary tumor in the fourth ventricle and large nodular suprasellar metastasis, as well as a metastasis associated with the cerebellar cortex. Several studies have sought to examine imaging features of the 4 subgroups of medulloblastoma. The Wnt subgroup has been associated with a cerebellopontine angle location in some studies, as pictured in the images in panel A. This pattern seems to be almost exclusive to Wnt tumors. However, the most common location for this subgroup is still in the midline, often displaying lateral extension towards the cerebellopontine angle. The sonic hedgehog subgroup can arise in the midline or in the cerebellar hemispheres. The midline location is common in infant tumors, where older children and adults often have a cerebellar hemispheric tumor, as depicted in panel B. Desmoplastic variants can display a nodular appearance, seen in the middle image in panel B. Group 3 tumors are often slightly smaller midline tumors with intense enhancement. Diffuse laminar leptomeningeal metastases are common. Group 4 tumors arise in the midline, and a differentiating feature is scant or absent contrast enhancement in up to 60 to 80% of these tumors. Metastasis in this subgroup may uniquely spread to the ependyma or suprasellar region, although other patterns of metastasis can occur as well. There are several important clinical prognostic factors, and numerous molecular prognostic factors have been proposed. Metastasis portends a poor outcome, and the Chang staging system is the most commonly used. Patients with M0 disease have negative CSF cytology and no radiographic evidence of metastasis. M1 patients have positive CSF cytology, but no radiographic metastatic disease. M2 patients have cranial metastasis, while M3 patients have spinal metastasis. Finally, the M4 stage features extraneural metastases, which are very rare. Of the patterns of extraneural metastasis, bone marrow metastasis are the most common. M2 and M3 stages are considered equivalent in terms of outcome, and in general, any Chang stage above M0 is considered high risk for the purpose of treatment allocation. Other clinical prognostic features are age under 3 and residual tumor of 1.5 centimeters squared or greater, or subtotal tumor resection. Patients with metastasis age under 3 or subtotal resection are all considered high risk, while the remaining patients are standard risk under contemporary protocols. Histological subtype also correlates with outcome, with MBEN having the best outcome, followed by desmoplastic nodular, classic, and finally LCA, which has the worst outcomes. Molecular features are increasingly being used in clinical trials. For example, the ongoing St. Jude's MB12 study first separates patients into either Wnt, sonic hedgehog, or non-Wnt, non-sonic hedgehog groups, and then further stratifies based on the clinical risk factors described above. Molecular features are likely to be increasingly incorporated into clinical trial design going forward, and several groups have proposed potential molecular risk stratification schemes. Some of these schemes are displayed in the figure on the right. These schemes are certainly more complex, with a combination of subgroup status, additional high-risk molecular characteristics such as mic amplification in group 3 patients or TP53 mutation in sonic hedgehog patients, and clinical risk factors such as metastasis, together are likely to provide a better prognostic estimate. More accurate prognosis is essential to optimize the selection of low-risk patients for treatment de-escalation to reduce toxicity and identification of very high-risk patients who are likely to fail with current therapy and should be prioritized for treatment intensification and the identification of novel therapies. Treatment of medulloblastoma is a team effort that starts off with surgery prior to risk-adapted adjuvant radiotherapy and chemotherapy. Patients often suffer from significant long-term consequences of treatment, and rehabilitation is essential to optimize recovery. Finally, given uncertainties regarding the optimal treatment of medulloblastoma patients, especially with influx of newly suggested prognostic factors, perhaps the best treatment that can be offered to a child with medulloblastoma is enrollment in a clinical trial. Treatment modalities will be discussed further in the coming slides. One of the goals of surgery is management of hydrocephalus. In rare cases, medulloblastoma patients may require emergent EVD placement. More commonly, these patients can be initially managed with dexamethasone and subsequent EVD placement at the time of surgical resection. This allows for management of hydrocephalus, decreases the rate of pseudomeningeal formation, and can enhance wound healing. The EVD should be weaned within a few days to a week postoperatively. For patients who fail to wean, it is prudent to proceed to shunt insertion, such that patients can heal from this procedure and proceed with adjuvant therapy. Of note, upfront shunt insertion or ETV is not recommended, as only 25% of patients will require permanent CSF diversion. Risk factors for this include younger age, larger tumor size, metastatic disease, and more severe or long-standing hydrocephalus. The Wnt subgroup also rarely requires permanent CSF diversion. Surgical resection is performed under general intravenous and endotracheal anesthesia. Patients are positioned prone, with head fixed in a 3 or 4 pin cranial fixation device and the neck slightly flexed. In infants, the head is positioned on a horseshoe headrest with careful padding to avoid pressure on the eyes. Care must be taken to avoid kinking of the endotracheal tube, and a nasal endotracheal intubation may be helpful. Goals of surgery are maximal safe surgical resection for cytoreduction, obtaining samples for histological and molecular diagnosis, and relieving mass effect. A midline posterior fossa exposure is performed, exposing from the inion to C2 with dissection in the midline avascular plane. The cervical musculature is dissected from the occiput and C2 in a subperiosteal fashion. The C1 lamina is subsequently exposed. Craniotomy is tailored to the tumor location and may need to be extended laterally for tumors in the cerebellar hemisphere or the cerebellopontine angle. C1 laminectomy may be required depending on the caudal extent of the tumor or degree of tonsillar herniation. The dura is open in a Y-shaped fashion, and bleeding can be controlled with hemoclips. These should be removed at the end of the case to avoid artifact on the postoperative MRI. Midline tumors may be visible at this point, extending caudally from the fourth ventricle between the cerebellar tonsils, as pictured on the left. Identification of the floor of the fourth ventricle is a key step in surgery. When possible, placing a cotton patty along the ventral aspect of the tumor, covering the floor of the fourth ventricle, can help avoid extending the resection beyond the tumor margin into the brainstem. Midline tumors can be approached via a midline Vermean approach or a telovelar approach. The margins of the tumor are dissected from the surrounding cerebellum microsurgically. Internal debulking of the tumor with suction and a cavitating ultrasonic surgical aspirator often makes subsequent dissection of the tumor margins easier. The tumor cavity should be inspected for signs of residual tumor, and intraoperative ultrasound can be a useful adjunct to identify residual tumor and direct further resection. Tumors in a cerebellar location require a corticectomy overlying the tumor, and subsequent microsurgical resection is similar to that described above for midline tumors. Following resection, meticulous hemostasis is achieved and confirmed with a Valsalva maneuver. The dura is closed in a watertight fashion, bone replaced, and overlying muscle, fascia, and skin are closed in a multi-layered fashion. Statistical analysis of many of the early clinical trial cohorts identified extent of resection as an important prognostic factor in medulloblastoma. Gross total resection and near total resection appear to have equivalent outcomes, but subtotal resection, which is defined as 1.5 square centimeters or greater of residual tumor, is associated with a worse progression-free survival in a multivariable analysis. This is depicted in the middle two survival curves. Retrospective analysis has suggested that this might be subgroup specific, with improved progression-free survival for group 4 patients who received gross total resection over a subtotal resection, seen in the bottom row on the right-sided figure, but not for the other subgroups, suggesting that subtotal resection may not result in worse outcomes in Wnt, sonic hedgehog, and group 3 patients. Surgical resection can result in new or worsening neurological deficits, including cranial nerve palsies, ataxia, dysmetria, or bulbar symptoms. Other common complications include infection, aseptic meningitis, hydrocephalus, and pseudomeningocele. Postoperative cerebellar mutism syndrome, also known as posterior fossa syndrome, occurs in 25% of patients and usually arises within 4 days postoperatively. It is characterized by diminished speech progression to mutism and additional symptoms including emotional lability, hypotonia, and ataxia. These symptoms usually improve or resolve over weeks to months. However, severe mutism is associated with permanent deficits, including ataxia and dysarthric speech. This syndrome is also a predictor of long-term neuropsychological impairment. Treatment protocols of standard risk children are fairly well established, unlike therapy for high-risk children and infants. Recall that standard risk children are those that are aged 3 to 18 with at least near total resection and no metastatic disease. Treatment consists of 23.4 Gray of craniospinal irradiation with a dose boost to 54 Gray to the tumor bed. Adjuvant cytotoxic chemotherapy consisting of 4 to 9 cycles of vincristine, cisplatin, and either lomustine or cyclophosphamide are then administered. This protocol achieves 5-year overall survival rates of approximately 80%. More aggressive chemotherapy regimens, such as myeloablative regimens with autologous stem cell rescue, do not significantly improve survival, but are associated with increased toxicity and side effects. Treatment of high-risk children over the age of 3 is more heterogeneous and currently results in survival rates of approximately 70% at 5 years. Higher dose of craniospinal irradiation is used in this subgroup, and some centers administer hyperfractionated radiotherapy. Various chemotherapy strategies have been attempted as well. Myelosuppressive techniques have resulted in reasonable outcomes in some studies, but poor outcomes in others. Pre-radiation chemotherapy regimens have also been used and resulted in over 70% survival. More aggressive treatment regimens using high-dose cyclophosphamide-based chemotherapy with autologous stem cell rescue, or chemotherapy that incorporates intrathecal methotrexate, also appear to have reasonable survival outcomes. The devastating neurological sequelae of craniospinal irradiation on children under the age of 3 precludes the use of radiation in the upfront treatment in this age group. Radiation may be deferred until the child is older than the age of 3 or when the tumor recurs. Some groups have used focal radiation to the tumor bed or residual tumor. Chemotherapy regimens are intensified to attempt to account for the lack of craniospinal irradiation. For example, chemotherapy regimens that incorporate intrathecal methotrexate are common. This can result in excellent survival for patients with complete resection and no metastatic disease, while survival for those with residual tumor is only 56% and only 38% with patients with metastatic disease. Myeloablative chemotherapy with autologous stem cell rescue is another strategy. Once again, metastatic patients have poor outcomes, but patients with localized disease had survival of 77% at 5 years. Histological subtype is an important prognostic marker in these patients, and the aforementioned trial showed that nearly all patients with desmoplastic or nodule tumors were alive at 5 years, while classic and LCA subtypes had poor survival rates of 53% and 46% respectively. Innovations in techniques to deliver radiotherapy promise to reduce the toxicity of this treatment in young children. Conformal boost radiation is increasingly used over a boost to the entire posterior fossa. This strategy reduces the radiation dose to nearby structures such as the cochlea and hippocampus. Helical tomotherapy is a technique that uses intensity-modulated radiotherapy with a spiral delivery pattern, which aims to provide a more homogeneous dose delivery to the target while reducing dose to the surrounding tissues. Proton beam therapy is an emerging alternative to photon beam radiation. This technique allows for far more precise delivery of radiation dose and sparing of surrounding structures, such as the vertebral bodies, which may reduce scoliosis and short stature, and to the heart, lungs, and GI tract. It is also more effective at reducing the dose to the developing nervous system, and improved cognitive outcomes have been reported in a recent trial. A small number of case reports have emerged that brainstem injury can occur as a side effect of proton beam radiation, and this requires further study. The use of radiotherapy can be limited by short-term adverse events and long-term toxicity. Common short-term adverse events include hair loss, fatigue, nausea, and vomiting. Late toxicities are a chief concern. Patients suffer long-term cognitive deficits resulting in decreased IQ, shorter attention span, slower processing, and memory disturbances, all contributing to a decrease in overall executive functioning. Other toxicities include endocrine deficits, short stature, scoliosis, hearing loss, cerebrovascular disease, cardiac toxicity, and secondary cancers. The incidence of secondary cancers at 10 years has been estimated at 4%, and malignant glioma, osteosarcoma, and myelodysplastic syndromes are the most common. Radiation-induced meningiomas may also develop in a delayed fashion. Chemotherapy is associated with a host of adverse events depending on the specific agents used. Myelosuppression is extremely common, with grade 3 or 4 toxicities reported in nearly all patients. Common side effects include fatigue, nausea, vomiting, anorexia, stomatitis, infections, and weight loss. Rare side effects include nephrotoxicity, hepatotoxicity, cardiomyopathy, pulmonary fibrosis, and GI toxicities. Alkylating agents are associated with the development of AML. Finally, chemotherapy can cause cognitive deficits, especially decreased processing speed and decreased adaptive functioning. Medullobastoma patients require upfront imaging of the craniospinal axis for staging at the time of diagnosis. If craniospinal MRI was not obtained preoperatively, it can be attempted with postoperative MRI to assess for residual tumor. However, detection of leptomeningeal metastasis can be obscured by surgical artifact and may need to be repeated 14 days after surgery to more accurately differentiate metastasis from artifact. Medulloblastoma patients typically have repeat clinical assessment and imaging every 2 cycles during chemotherapy and every 3 months during the first 2 years of follow-up. Patients with stable disease then have follow-up extended to 6 months and eventually to every 12 months. The Response Assessment and Pediatric Neuro-Oncology Committee has published recommendations regarding the imaging protocols and definitions for treatment response, which are of particular importance for patients enrolled in clinical trials to ensure standardized assessments. A recommended protocol is seen on this slide. Medulloblastoma can recur locally, metastatically, or both. Recurrence patterns vary by subgroup. Wnt tumors have excellent outcomes and recurrence is quite rare. Among the other subgroups, approximately 70% of cases recur in a characteristic pattern, with sonic hedgehog tumors usually recurring locally, and group 3 and 4 tumors recurring metastatically. Group 4 metastasis can be delayed, with a notable number of recurrences occurring 5 years after initial diagnosis. Patients with recurrence have survival rates of approximately 10%. Treatments including repeat resection, additional chemotherapy, repeat radiation therapy, targeted treatments, and stereotactic radiosurgery have been attempted, but result in generally dismal survival. We have a limited understanding about the biology of recurrence, other than that subgroup status is retained. Biopsy of locally recurrent tumor is important to differentiate from radiation-induced glioblastoma, and biopsy of recurrence will likely become increasingly important as targeted therapies are developed. Medulloblastoma survivors often experience decreased quality of life related to neurological deficits caused by the tumor or surgical resection, as well as the impact of radiation and cytotoxic chemotherapy on the developing brain and other organ systems. This results in a reduced health-related quality of life, and these scores can vary from mild to severe, depending on factors such as age at diagnosis and craniospinal irradiation dose. Neurological deficits caused by the tumor or surgical manipulation can impair motor skills or coordination. Hearing loss can occur as a result of radiation dose to the cochlea and ototoxicity related to cisplatin chemotherapy. Adjuvant therapies can also impair cardiorespiratory function. Cognitive impairment is among the most common side effects of current therapies. Craniospinal irradiation has deleterious effects on the developing nervous system, causing white matter damage and decreased hippocampal volume. The effects are more significant with younger age at the time of treatment. Of particular relevance to neurosurgeons, postoperative cerebellar mutism, or posterior fossa syndrome, is a strong predictor of long-term neuropsychological impairment and occurs in up to 25% of medulloblastoma patients. Recent work has suggested that MRI biomarkers, such as midline location, bilateral middle cerebellar peduncle invasion or compression, and dentate nucleus invasion, along with age over 12.4 years, can predict postoperative mutism. Surgeons should be aware of these risk factors and consider a more conservative resection of tumor in high-risk areas. Furthermore, functional MRI may be a helpful tool to visualize functional circuits to guide operative approach. The combination of these physical and cognitive adverse events result in only 40% of survivors achieving functional independence. They also have lower rates of educational achievement and employment. Current studies are looking at techniques such as exercise therapy and computerized training to improve working memory skills and induce cognitive restoration. Thank you for listening to this presentation. I'd like to conclude with a few thoughts on the future directions of medulloblastoma research. The discovery of the molecular subgroups has provided a promising path forward for the treatment of medulloblastoma, a disease which has had relatively stagnant survival rates over the past few decades. The overarching goal of the next generation of trials is to reduce treatment-related toxicity for patients while retaining excellent survival for low-risk patients, and to identify improved therapeutic strategies for high-risk patients likely to relapse with current treatment strategies. The molecular era has provided a tool to identify these patients correctly, and the goal is to use improved understanding of tumor biology to advance promising preclinical therapies to clinical trials. Reducing the toxicity of radiotherapy using different radiation sources like proton beam radiation and altering how the dose is delivered, for example, tumor bed boost rather than posterior fossa boost, shows promise in decreasing radiation dose to surrounding structures, both in the brain and throughout the body. Radiosensitizers may also allow for some reduction of radiation dose. Patients with metastatic disease and recurrent disease have very poor outcomes with current therapy. Existing evidence suggests that the biology of metastatic and recurrent disease is different than the primary tumor, and this requires a better understanding of the biology that drives these processes to identify improved treatment strategies. Neurosurgeons have a key role to play here in that biopsy of recurrent disease is likely to become essential to guide therapy at relapse. Finally, neurosurgeons must integrate new technologies to refine operative techniques in an effort to reduce rates of devastating complications such as cerebellar mutism. This may be achieved by a better understanding of the location of functional tracts in each patient relative to their tumor location and being less aggressive with surgical resection in high-risk anatomical regions. These considerations may be especially pertinent for non-group 4 tumors that recent evidence suggests may not require as thorough resection as previously thought. Such intraoperative decision-making will require more accurate subgroup classification based on radiographic assessment or the development of rapid subgroup diagnosis that can be performed intraoperatively. For a complete list of references relative to this PowerPoint presentation and the textbook chapter, please see the online edition of the text. Images in this presentation were obtained with permission from the following journal articles: